Greetings, everyone, and welcome to the Brighter Futures session of the 2021 Mental Health Science Summit. I'm Carol Worthman, and together with co-host Cassandra Lovelock, we'll be moderating this panel where you will hear about innovative work on the detection, treatment, and prevention of mental illness, particularly in young people. Although adolescence is a period of tremendous developmental gains and opportunities, it also is a time of greatest risk for onset of mental and behavioral problems. Therefore, MQ has recruited top scientific talent to promote brighter futures for these young people and allow them to reach their healthy potential. In this panel, you'll learn about the work of Brighter Futures scientists and its significance. Their work illustrates the impact of strategic investments in fresh approaches in mental health science and PPIE, or embedded patient and public involvement and engagement. First, we'll hear from three presenters. Then I'll add a few remarks, and then we'll open it up for questions and discussion. I hope you'll have some. And we also hope that the presentations will spark new ideas, reveal fresh possibilities, and open potential collaborations. Be prepared to be intrigued and inspired. Now I'll turn it over to Cassandra Lovelock to introduce our first speaker.
Thank you very much, Carol. Firstly, we're joined by Anne Joan. She joins us from Swansea University. Anne is a clinical epidemiologist by background with research focusing on self-harm and suicide prevention and the risks, protective factors and life course outcomes of children and young adults' mental health. Anne leads on the MQ-funded Adolescent mental health data platform, which she'll be presenting about today. Go for it, Anne.
You're muted.
Not a good start. Thank you, Cassie. So when I'm talking about the Adolescent mental health data platform, particularly at research conferences, it can seem quite dry because it's infrastructure, but it's really important infrastructure because one of the issues that we found as mental health data science has evolved is that, the linkage of novel data sets. So, we're all used to working with either data that we've collected ourselves or in very specific, say I started off with electronic health records. And there are two issues with that. So one, often we're not sharing how we've sort of stacked our data. So when we're working with survey data, it's all nice and clean and tidy. With routinely collected data, there's an awful lot of data cleaning that goes on. And if each individual researcher was doing it themselves, instead of doing the exciting part, like the analysis and interpreting the results, we spend 3/4 of a project making the data usable. And what the platform's about is having that work done, and so that people can get on with research-ready data. So within the Adolescent mental health platform, we almost had sort of 3 work streams, which we call create, annotate, and collaborate. And so the first one was about doing research, and that happened on 2 levels. One, it was research carried out by my team into adolescent mental health. The second was to collaborate with researchers both across the UK and internationally, but also across disciplines. So one of the beauties of infrastructure, mental health infrastructure, to sort of safely, securely, privacy protected, trusted research environments to house data, is that you can bring researchers from across sectors together. And there's nothing that can do that in quite the way that linking two data sets together can. So prior to doing so much work in data science, I come from a real social determinants background. So the sorts of analysis that I was doing was really looking at underserved groups. It was looking at deprivation, both area and individual. I never really spoke or worked with people working with genetics data. But when we linked those two data sets together, over the last 5 years, we've worked really closely. So I really think this sort of infrastructure is about creating those biopsychosocial models that are really the determinants of mental health and getting researchers to think together. And I think it's at those interfaces of different disciplines that we're really going to see innovation happen both in our understanding and management of mental health. So we worked with innovators at Swansea University who are world leaders in creating trusted research environments with, you know, access and security and privacy processes. We set up governance procedures so that there was a lot of like nitty gritty that we had to do before we could get down to the research and work with people doing research. There's also what you'll find in this field is that we're working with data that gets entered by people who aren't thinking about research. You know, they're going about their daily day-to-day jobs and they're entering data and diagnoses. So you have to make code lists to find people who have certain disorders or symptoms. And if you look across many studies, many of those code lists are different, which basically means a fundamental criteria of research. What we're measuring is different across studies. And what the ADP does is it creates those lists, creates algorithms to run those lists so that people are measuring the same thing. So over the last few years, we've done all that. The ADP is there, it's ready to use, it is being used. You know, one of the big things that we did is work a lot with young people. So I remember the first time I worked actually with the MQ Young People's Advisory Group. And I had, you know, I was talking about the research, I was talking about adolescent mental health. What they were interested in was how do we anonymise data? And that surprised me. However, we went away with that. We have mental health champions and young people working on the ADP, and we created a video about anonymisation. And following on from that, we've worked really hard to try and work with underrepresented groups. We're doing projects in young people from Gypsy Roma traveller groups, from ethnic minorities, and this work led on to one of the MRC engagement projects where we've basically been funded by the MRC to work directly with young people from underserved groups about their data, because these groups, due to their experiences, may well have a very different feeling about their data being used and discoverable. Sorry, the slides have gone back. So some of the research we've done, we looked at self-harm presentation across healthcare, in primary care, secondary care, and emergency departments. One of the things we found was that boys with the same presentation of self-harm to ED were much less likely to be admitted than girls. So although we push for help seeking in males and young men, potentially we as a society and as practitioners respond differently to young boys in distress. We worked with teachers and social services and health professionals and created this guidance that was disseminated across all schools and settings in Wales and is going to be adopted in Scotland about how to talk to young people with self-harm. We've created a partnership with the Nuffield Criminal Justice Observatory. So this is really two sectors coming together. And in an area of family court where large at-scale studies, particularly about the mental health effects of, you know, we know a lot about safeguarding, less so about private courts. We have linked to CAFCAS data, which is the court data, to mental health symptoms and diagnoses in primary care data and secondary care data. So there's a couple of ongoing projects in that. So this really is an area where you can innovate. Over the last year, we had to rapidly pivot around COVID, alongside, I'm sure, everyone else here. We did a lot of work looking at presentation to services and the drop that's now well recorded. We also, I do a lot of work in suicide and self-harm. I co-lead a global suicide study. And because we had the infrastructure, because we had that data safe haven, we've worked with 27 countries to use their real-time suicide surveillance data to look at what was happening to suicide rates over COVID.
Dr. Yeah, thank you so much, Anne. I know you have so much going on, and this will link in nicely. The suicide work will link in beautifully to a later presentation, and it's a wonderful demonstration that data matters, and it's really about people. So this is great. Thank you so much. But we're going to have to press on and move on to our next presenter, who is Valeria Mondelli. She's at the King's College London and King's College Hospital with a medical degree in psychiatry and a doctorate in psychological medicine. She focuses on the role of immune activity or inflammation in mental illness and how that also links to risk for physical illness. Today, she'll tell us about the MQ-funded IDEA project, which is a multinational collaborative team effort which she leads. This initiative aims to identify predictors and inform preventive intervention for depression in youth, and as we'll hear, has led in many exciting directions. Over to you, Valeria.
Thank you very much, Carol. Thank you for the invitation, MQ, and thank you for the kind introduction. So I'm going to talk to you today about our IDEA project. And for us, as Carol mentioned, IDEA stands for Identifying Depression Early in Adolescence. So the main objective of the IDEA project has been to identify biological, psychological, and social markers that could help early identification of adolescents at high and low risk of developing depression. And in particular, markers that can be feasibly assessed across high and low middle income countries. And this is quite important because 90% of the adolescents globally actually live in low and middle income countries. And by identifying depression early in adolescence, what we really want to achieve is to help developing more effective preventative and treatment strategies for adolescent depression. So one of the first work we conducted as part of the IDEA project was to consult with experts in the field about risk factors for adolescent depression by conducting a Delphi consensus study. And as you can see here from a figure from the paper, the panelists ranked 31 risk factors for adolescent depression on the basis of their feasibility of assessment and their specificity for depression. And the panelists ranked 3 as highly specific and highly feasible to measure. And these were family history of depression, exposure to bullying, and a negative family environment. But one of the main concepts really behind the work of the IDEA project is to not focus only on one risk factors, but combining multiple risk factors together. This is what we learn basically also from other fields in the medicine. That is, it's only when we combine multiple factors together that we can increase the accuracy for identifying individuals at risk, and in our case, identifying the adolescents at high risk of depression. So this is what we did. So we developed a composite risk score. So this is basically an algorithm of 11 different socio-demographic variables that are easily obtainable directly from the adolescents, and that include things like exposure to childhood maltreatment, relationship with parents, use of recreational drugs, and so on. And combining all these factors together increase our accuracy of predicting future episodes of depression than by looking at each factor on its own. So with the information about these factors collected at age 15, we were able to predict who was going to develop depression at age 18. And we tested our IDEA composite risk score in different longitudinal cohorts of adolescents. And here are some of the papers we published so far in a cohort in Brazil, in UK, in New Zealand, in Nepal, in Nigeria. And we recently also did it in a second cohort in Brazil and in one in the US. And what you can see from the graph is that our results were not perfect, but were always beyond chance, so beyond 0.5, in being able to identify adolescents at high risk of depression. And what is important is that we were able to replicate the findings, even though we did not have all the information about the 11 factors in all the studies. So this is very promising, but the composite risk score, as I mentioned, is mainly based on socio-demographic factors. And if we want to understand better how adolescents develop depression, we need to understand also what is happening at a biological level. And in particular, what we learned also from our systematic review here of the literature is that the interaction between environmental stress factors and biological markers is very important in determining really the increased risk of adolescent depression. So in particular, in this review, we show how the experience of childhood traumatic events interact via both a moderation and a mediation pathway with biological abnormalities to increase the risk of depression in adolescents. So suggesting that these biological abnormalities, such as the increased inflammation or some neuroimaging markers like blunted reward-related activity, are a very important step in determining whether someone who has been exposed to childhood trauma will or will not develop depression later on. So to understand better then the neurobiological profile of the adolescents at high risk of depression and potentially to identify better targets for prevention and treatment, we decided to use our IDEA risk score to recruit a new sample, stratified sample of adolescents. And in this case, then we used the IDEA risk score so that we recruited 50 adolescents without depression who were at low risk of developing depression according to our IDEA risk score, 50 adolescents without depression but who had high risk of developing depression, and 50 adolescents with depression. And in all of these adolescents, we collected blood and saliva samples and did brain scan to look at the neurobiological markers. So we are still analyzing some of the data, but I really want to give you a sneak peek on some of the results. So here you can see these are very interesting neuroimaging findings. So where you see in the graphs is the adolescents with the low risk are represented by the blue bar, the adolescents with high risk by the green bar, and the adolescents with depression in the orange bar. And what you can see here is that both the adolescents at high risk and the group with depression showed a reduced activity in the dorsolateral prefrontal cortex and in the ventrolateral prefrontal cortex, which are brain regions implicated in integrate the rewarding information and goal-directed behavior. So the observation that these patterns were observed both in the high risk and in the patients with depressions suggests that these may actually be neural markers of depression risk. We also looked at the inflammation, and these are some of the initial findings. So you can see here that some of the results show that interleukin-2, which is a pro-inflammatory marker, is higher in adolescents at high risk and those with depression compared with the adolescents at low risk. But this only in boys, which are represented in the graph by the blue bar, by the blue line, sorry, but not in the girls who are represented by the red line. So this suggests that some inflammatory pathway may be important for increasing the risk of depression, but that this may differ between boys and girls. So further supporting the role of the inflammatory pathway in the development of depression are also some of the findings that we have from the gene expression data. And they show that there is an increase in expression of inflammatory pathways in adolescents with depression when compared with those at high risk. So this is just to kind of show you also what we are going to do next. Some of our next steps are really been focusing on following up this very well phenotyped cohort of adolescents. We have now completed the follow-up the first year. This is an online follow-up, and currently completing the follow-up at year 2. And with potentially more funding, also we will conduct a complete also face-to-face follow-up at year 3, where we are hoping to complete more neuroimaging biological analysis to understand how these biological markers change over time in association with the development of depression. So I'm going to stop here. I just want to acknowledge, all the fantastic work of the IDEA family. Here you can see only the names of the co-investigators, but it's much more than that behind the scenes. In particular, I want to acknowledge Christian Killing, who is also a co-PI with me of IDEA, and all the fantastic postdoc, research assistant, early career scientists who have really contributed to all the findings that you have seen today. And of course, a big thanks to MQ, without which support we couldn't achieve what we have done today. So thank you very much.
Thank you, Valeria. That was really interesting and beautifully on time. So wonderful. Our next speaker is Anne-Laure Verhaemelen, I think. Sorry. She joins us from the Brain Safety and Resilience at the Institute of Education and Child Studies of Leiden University in the Netherlands, and is an honorary senior affiliate of psychiatry at the University of Cambridge. Anne's research focuses on understanding pathways between childhood adversity and psychobehavioral risk and resilience in adolescent by tackling the interplay of social, psychological, and neurobiological factors. Today, she'll discuss a multinational collaborative HOPES, H-O-P-E-S, project that she has headed with support from MQ. We're really grateful to have you with us, Anne-Laure, if you want to take it away.
Thanks very much. So thank you very much for the invitation to speak here about HOPES. Now, the HOPES project stands for Help Overcome and Prevent the Emergence of Suicide. It's a collaborative project across the globe with leading experts in adolescent suicide, such as Hilary Bloomberg and Liana Smau. Now, imagine a disease that killed almost 1 million people a year, and a quarter of them being before the age of 30, and yet not knowing much about why some young people are vulnerable to this disease. Now, this is where we are with adolescent suicide. So every 40 seconds, someone dies by suicide globally, resulting in about 800,000 suicide deaths each year. And globally, suicide is the second leading cause of death for young people. And these rates seem to be increasing. And up to 1/3 of all teens think about suicide, and approximately 1/3 of them report making an attempt in the past year. However, as of yet, we don't know who these adolescents are. So it's absolutely critical, even life-saving, that we better understand the factors and mechanisms that place young people at risk for suicide. However, unfortunately, our ability to predict suicide and suicidality in young people isn't good. It's very poor, actually. A recent meta-analysis published in 2016 included that our ability to predict suicidal thoughts and behaviors was poor. They included 365 studies from the past 50 years and concluded that by and large, the field seemed to have conducted the same study, looking at the same type of risk factors over and over again for the past 50 years. Now, this meta-analysis was published in 2016, and I'm happy to report that since then, very many important empirical studies have been published by, for instance, Becky Mars and Rory O'Connor and Anne John. So I'm happy to say that the field has really reached a turning point and moved beyond it. But this was a situation where we found ourselves when we started the HOPES project in 2017. Now, the HOPES project was keen to investigate a novel risk factor a novel risk factor, namely the brain and its role in aiding vulnerability to suicidal thoughts and behaviors. Because at the time, not much was known about this. So we started by conducting the most thorough review of the literature. We looked at all research articles that used any type of brain imaging methods to investigate the brain in individuals with suicidal ideation and behaviors. And in total, we were able to include 131 studies. We identified 2 brain networks that were important across all these studies. That one network included regions important for emotion regulation, whilst the other network was important for decision making and the control of our behaviors. Now, if both of these networks are altered in terms of their structure, function, or biochemistry, this, we felt, might lead to situations where an individual thinks negatively about the future and is unable to control those thoughts, and therefore might lead to really high-risk situations. These findings were an important step in our ability to understand suicidality from the point of the brain. However, these findings were also based primarily on studies in adults. Now, as you can see here from this graph, there was an increase in neuroimaging studies over the past decades. However, those studies have primarily focused on adult samples. Only the orange bit here is depicting the adolescent samples. So only a handful of studies were actually looking at adolescent brains. So to generate more knowledge on the mechanisms of suicide, we decided to develop a special issue on Journal of Affective Disorders, where we invited researchers globally to contribute their latest research or perspective. And this led to 20 studies showing that there are many different mechanisms that may contribute to suicidality, including social, psychological, and neurobiological mechanisms. However, despite hopeful progress in these studies, more research on adolescent suicidality was urgently needed. And I'll tell you why. So gaps that we identified in our knowledge of adolescent suicidality, for instance, in the level of the brain, are depicted here. But the most important gaps of our knowledge is due to the fact that the majority of studies have too few participants to draw reliable conclusions that can generalize across populations. And these studies primarily examine suicidality and the brain at the same time, making it impossible for us to know whether or not these brain mechanisms actually predict behaviors over time. And furthermore, the majority of these studies do not examine risk factors together. So it's unclear how the brain mechanisms and the cognitive mechanisms and the social mechanisms interact together. So we aim to solve this in hopes. And we started by running the largest brain study on adolescent suicide to date. This brain study aimed to look across mental disorders and examine the mechanisms of suicidal thoughts and behaviors. To do so, Lianne Smaal and Laura van Velzen set up the largest global collaboration on suicidality, the ENIGMA STB consortium. This consortium now has 65 cohorts from 6 continents involved, and these different groups have shared information on their participants with us. And you can see that we have data on more than 13,000 individuals at the moment. And for this project, Lianne has expanded the research to also include adult populations with the help of additional funding from the NIMH. Now, in this large data set, Lianne and Laura were particularly interested to see what the brain looked like for young people with current suicidal thoughts and behaviors. And what they found is that the red regions depicted here were just a little bit smaller in 15 to 18-year-olds with a history of suicide attempts. Now, these differences were very subtle and small, but they were found in regions that are very important for decision-making, control over our behaviors. So from these findings, however, we can't determine whether or not these alterations actually predict future behaviors. So Hilary Bloomberg and Lila Coolidge at Yale were particularly keen to help address that question. So what they did is they examined a subset of data from Yale and Cambridge from young people who had clinical assessments for mental disorders and a brain scan that were followed up sometime later. And what they found in this data set is very strikingly that 58% of the sample had reported past suicide behavior. And at the time of follow-up, 43% had reported new suicidal behavior at follow-up. 28% reported suicidal ideation at follow-up. And only 28% reported no suicidality at follow-up. Now, Lila and Hilary then compared the brains of these three different groups. And what they found is that they found differences in the structure of regions important for emotion processing and the white matter tracks connecting these regions. Now, when we discussed these findings with the Young People's Advisory Panel from MQ, the panel suggested that these brain findings are important, but we shouldn't forget about other important mechanisms, including anhedonia, emotion regulation, rumination, and also social experiences such as childhood adversity and recent stressful life events. So Maria Dauverman in my lab aimed to investigate how these different mechanisms relate to each other. So she tested a model looking at brain regions and the structure of these brain regions, cognitive functioning, and recent life stress. And what she found is that there was no relationship between the brain and suicidal thoughts when looking at all these things together. But we did find that there was a really strong negative relationship between recent stress and the brain. Although from these findings, we can't say whether or not this represents the effects of stress on the brain or whether this represents a brain vulnerability that inadvertently generates more social stress for these young people. So we'll be investigating this further. These findings from the HOPES project, they indicate that there might be important brain mechanisms that play a role in current and future suicidality, and that it's critical to take social experiences into account. Furthermore, our project has really important clinical implications and research implications because we found really high rates of past and also future suicidal thoughts and behaviors in clinical samples that weren't selected or invited necessarily for their suicidal thoughts or behaviors. So this is really of importance to all the mental health researchers at MQ. Finally, we emphasize the importance of integrative research that looks at developmental trajectories, especially within high-risk populations, such as LGBT youth, because whilst this group might have the highest suicidality rates, virtually none of the studies that we included have data on this. So, in sum, hopeful progress, but much more research is urgently needed to help prevent and overcome the emergence of suicide. And I'd like to thank my team.
Thank you so much, Anne-Laura, for a fantastic presentation, and to all three of our panelists for a really interesting set of presentations that we could discuss for a long time. And I'm sure that our audience has been inspired and enlightened by your findings and comments. And we have a variety of things we want to discuss shortly. Just to get us started, I wanted to point out how we've sort of achieved liftoff in many ways in terms of the combination of social and biological, including brain sciences, along with epidemiologic sciences, to really take our approach to mental health beyond the discovery phase into really engaging with science that makes a difference for young people and for people in general. And the other thing that I think you can see from these presentations is the way in which this scientific effort is going global. And that's super important because it was recognized over 10 years ago that what we knew was largely based on affluent post-industrial societies and didn't really well represent necessarily what's going on in low and middle income countries where the majority of people live. So I think it's also exciting for us to see what we're learning as we expand these modes of inquiry to other settings. And then lastly, I think, I don't know about the rest of you, but I have not always been a data geek, but I've become more and more excited about the possibilities of making data talk and using data in ways that, rather than effacing individuals, actually better represents the diversity that is out there. Now, I'm just being told that I'm muted. Can you hear me? You look like you can hear me. Okay, all right. Random, random static from the universe. We're also seeing in all three of these studies ways in which data are being deployed to really produce a biopsychosocial approach to mental health problems that also integrates them within the larger framework of well-being. And I think we're all really interested in that. What are the ways in which we can promote flourishing, not just prevent all the bad stuff, but also you can see in each one of these talks ways of that we can imagine promoting flourishing. And then lastly, we could talk a lot about this as well. There are the ethical issues that are really brought forward when we engage people who are themselves affected by the work that we do and who are struggling with the issues that we have, which, by the way, is everybody. Right? Who of us does not know someone who is struggling, or I'll speak for myself, the last year hasn't been an easy one, right? And so how we connect these macro structural issues like the pandemic that really reveal how connected we all are to the individual, well, the local contextual household or social unit and individual, and then down into the molecular level, we're seeing how all these work together. And so these are exciting, fantastic moments for us to really move forward to benefit the people that we hope to help with mental health science. So those are my little remarks because I really want to get us, turn it over to Cassie so that we can get started on questions and discussion.
Thank you, Carol. I thought we'd start with a question we've had submitted for Anne John. So someone has asked that you appear to have data on the impact of COVID on adolescent suicide, and unfortunately you were cut short in your presentation, so if you could spend just a minute talking about that, that would be great. Thank you.
So this is, I'm co-leading this with Prof. Jane Perkis in Melbourne, but also with David Gunnell and Matthew Spittle. And we've worked, basically everyone's worked with researchers they know around the world to get real-time suicide data. So, and I guess one of the difficulties is exactly what Carol highlighted, in that it's been really hard to get data from low and lower middle income countries. So the data we have currently, because, you know, as everything in the last year we were rushing, is about adults, and what we found now has been widely reported is that, you know, it looks like in the early months of the pandemic, so up until about September, October, there was definitely a drop in suicide rates in many a drop, or they stayed the same in many countries around the world. Now, because the ADP was there, we were able to reassure people that the data would be held really securely. So now we're going through an exercise where we're going back. So we're regularly collecting this data to look at suicide in young people around the world. I think what we've seen from other studies is that there was a study in the States where, although overall rates stayed the same, there does seem to be a concern in some places in the States and in Japan that it is increasing in young people. We need to be, but then in other places we're not seeing that. I think what we need to be vigilant about is that in the early part of the pandemic, there were lots of financial and employment protections put in place around the world in the countries that we've got data from. And most of those protections are going, and that we are entering a recession. So what I always say is the data we had, while reassuring, was early on in the pandemic, and things may become very different.
Thank you, Anne. That was a really lovely response. That's great. We've had a couple of questions around PPIE, and I know that's quite important to MQ, so I thought I'd ask Valeria. It's been said that you said a part of your study, like sort of your work, involved working with PPIE, and where you found that not everyone was interested in being able to predict risks of depression. Is there sort of anything you can comment on that to expand on?
Yeah, absolutely. I mean, we did quite a lot of work with the adolescents themselves, as well as with actually, parents and healthcare workers locally. And there were different recommendations. So this is really a work that is being led by Brandon Court within the IDEA consortium. And there were, of course, things raised about the need to ensure confidentiality when using a risk calculator, to ensure, that there was not stigma about the fact that you were identified as being at risk. And of course, a lot of the conversation was also about, once you identify me as at risk, are you going to offer me something to kind of reduce my risk or not? So this is actually the next step that we are trying to work on, because of course we realize that this is extremely important in the process for developing a better prevention. And of course there's been a lot of discussion about what is the best environment where to use the risk calculator, and the schools were actually considered well positioned to do that, but with the important training in how to administer eventually the risk score. There were quite a lot of different things about also the suggestion of using digital technologies to apply to use the risk calculator in adolescents who are really much more in a way used to use these technologies than probably my generation. But I think it's been extremely helpful in understanding how to use eventually the risk score going forward, and what is the next research that we need to do. So it's been incredibly helpful, yes.
Thank you very much, Valeria. I was wondering, in a similar question to you and Laura, if that's okay. In your presentation on suicide points, you mentioned a little bit about PPIE, and I was wondering if you wanted to expand on that. You're very welcome not to, though.
Yeah, thank you. And I think it's an important question, because one of the most important issues raised by the young people is actually the issue of stigmatization. So the idea that if you're looking at the brain and its relation to suicidality, that you're therefore saying that there's some deterministic or causal relationship, which I felt was really important that we make sure in our studies and in our the way that we talk about suicidality and the way we publish our papers, that we don't say or mean or infer that if we find a brain mechanism for suicidality, so that is in any way causally related with any behavior, but rather that there might be an important contribution or an important vulnerability that might play a role in a context of many other important factors. And that I found was a really interesting and important contribution from the young people. And the contributions that they mentioned was like, well, if you're looking at the brain, then that means that you feel that there's nothing that we can do about it. And we had these really interesting conversations about how even social factors could actually help shape brain development. An example of a negative one is early life stress, but what we also know is that positive experiences in adolescence can actually help aid, for instance, stress responses in a better manner. So whilst looking at the brain, it's really important to take its environment into account, and that was really something that the young people stressed.
That was wonderful. Thank you so much. So we're sort of coming towards an end, so I thought we'd ask one last question for each of you. You've all mentioned sort of here or there sort of the next steps or what to look for in the future. So if each of you could give 30 seconds to a minute towards just talking about what's the next steps in your research and where MQ are involved, that would be great. Does anyone want to go first, or shall I pick one of you? All right, I'm going to pick Anne without an E.
So basically, we want to expand the researchers we work with, the researchers we do. I think one of the things that we found over the last year, looking particularly at suicide studies, is that the percentage of studies on young people is much smaller. It was like 10% in a review we did of all the research on suicide. So we're going to focus on that. But we've partnered with MQ and King's and, well, about 10 other universities and across sectors. And we've just had funding announced for basically a much bigger data platform called, which is an HDR UK mental health data hub, called DataMind, where basically one of the things we really want to address is young people's discomfort with the use sometimes of their social media stuff without consent, and then also sometimes the discomfort that people feel about industry having access to data. People feel quite comfortable about researchers and academia having, and I think that part of what DataMind will do is bring all those different people together to have those discussions about how those things can be done responsibly.
That sounds really important, and I look forward to reading about it as it develops. So, would you like to go next, Valeria?
Yeah, sure. Thank you. I mean, we have different levels of next steps for IDEA. So one, of course, as I mentioned, is really following up this stratified cohort to understand better the interaction between the biological and the socio-demographic environmental risk factors in predicting the development of depression. And the follow-up is extremely important because it's the first time that we actually have recruited adolescents already knowing at what level of risk they are, and collecting originally also a lot of biological data. So this is an extremely important cohort and work to do in the follow-up. But of course, the other two steps that I want to kind of mention is what we want to do is to have more collaboration. So if someone is out there with other cohort of adolescents longitudinally, we are really keen to explore the risk score in other cohorts to understand how we can eventually improve better the risk score, or what are the differences in different contexts to improve it locally for the different countries. And the final thing, I don't want to take too much time, but it's also about using the risk score eventually to personalize the prevention strategies later on. Because we know that knowing what are the risk factors, we may be able to do better treatment by focusing on what is relevant for that particular individual. So it's quite a lot of work, but we are really keen to go forward with that. Thanks.
Oh no, that sounds amazing. I hope you find someone to partner with. So lastly, can we come to you, Laura, just about the next steps in your project?
Sure. So there are, like Valeria, many steps that we are planning to take. I'll mention a few of them. So one really important one is that the latest studies in the subsamples, the follow-up study and the integrative model study were in smaller sub-studies. And the reason for that is that we haven't yet fully harmonized all the data in the ENIGMA STB cohort. So that is a really important next step that we want to take, is running these more complex models in these bigger data sets, so that we can actually also explore the effects of gender, because there are really important gender effects in suicidality rates, but I haven't mentioned them at all in my talk. But there are other important aspects that we want to explore. We want to better understand what kind of therapies are differentially affecting these brain mechanisms, if they are, and if they can modulate or moderate the relationship between the brain and suicidal behaviors at later stages. So another really important aspect that we want to look at is, are there different developmental trajectories that may play a role in vulnerability to suicidality in young people? So for now we've been kind of putting all the adolescents together, but a 12-year-old is not comparable to a 17-year-old, and looking at their brains, you should take that into account. So there are really important next steps that we want to take in that sense.
Well, lovely. I think that wraps up our session, and I want to thank all our presenters and our audience for a really interesting session. I hope it makes you all feel a little brighter about our futures. And I, for one, am really inspired at what is being done to make that happen. So thank you, everyone. A pleasure being with you all.